Thank you for coming to this parallel session. I'm Richard Nicholas. If you don't know me, I'm one of the consultants who we started off using Natalizumab. And this day started off really because of the challenges that Natalizumab brought up. And those are continuing, but as we see, it's now a parallel session. There's a lot of other things happening in the world of MS that are quite exciting that maybe this is part of, but there are a lot of other things to talk about. So in particular, I'm going to talk about Natalizumab and how it's worked with us and over the years. And the question that keeps being asked really is, well, what's the plan? What's going to happen? What's plan B? And a question that also occurs to us as well. And so I'm going to try and address it through what's happened to us over the last few years. So this isn't lots of trial data, this is what's happened to us. So I just need to put my, I'm quite dirty, so I wouldn't believe a word I say generally. But really, firstly, I was going to talk about how well Natalizumab has been for a large number of people since 2006. I'm going to talk about some of its known risks, PML, one that we're all concerned about, and the new treatments and how they sit in with Natalizumab, and are they better? How do we feel about them? How are they going to fit into the mix? And really, what are my options? So we know that Natalizumab is effective on relapses and disability. So this is something that we've done for some years. I've shown this slide, which shows this is from people treated here and their relapse. So people having 2 attacks a year in the year prior to having starting treatment, going right down to about 0.25, so a quarter of attacks, so a 76% reduction in the attacks. What we found is that, that's only over 1 year, is that this is the trial that was done in 1996, the original 2006, the original trial, and what it showed is that people were given placebo, which was a dud, or the real treatment, and there was a 68% reduction in the people who had the real treatment. But if you look at the information that was provided, that there was a relapse rate of around 2 before, and again 82% reduction. So essentially, Natalizumab was doing what it said on the tin. It seems to be reducing relapses. That's at 1 year, and 1 year is not a life. So this is the information, this is the top study, which about 50 people from here, or 58 people from here, have formed part of over the years, and this is 4,800 people over the world globally who've been on this treatment. And what we see is the relapse rate drops dramatically to around a quarter, and it remains for up to 5 years. So I think the treatment is looking like it does work on cutting down the attacks over 5 years, which is good for us. We're still ongoing in this study. The numbers are different. You can see the numbers do get smaller, so this is an open study, so we do see this. The other issue is about disability. So in MS, we measure disability using this EDSS score, which is on the side on this axis here. And what this is, the people who were on the original trial, the grey were on the real treatment, and on the placebo treatment, and the Natalizumab was the people who had the active treatment. This gap occurred in 2006 when PML occurred, but people restarted it. But what we see over time is essentially that people are remaining stable. So this is again up to about 6 years, 5-6 years. We also see that the people who were on the original placebo were a little bit worse than the people on the original treatment. So there is an argument for starting treatments sooner rather than later. So that's partly reinforces that argument, but what we're seeing is stability. So people getting on with their lives. What we've done here with people who we've treated here and everyone here is we've taken the people who've been treated actually for about over 2 years, and we measured their disability using this EDSS score, and we divide people into what we call non-responders and responders, and they have various steps on the score. This is used internationally. So it's an international measure of what we are. And what we see is that at 1 to 2 years, 81% of people are responding, which is a good figure, but it's only 1 to 2 years. But up to 7 years, we're getting now 63% of people are still remaining stable or improved. But half of those people improved, half of people stable. So we're seeing long-term benefits and stability in the condition. And as I think Siddharthan has just mentioned, we've got the autoimmune element of the disease, and then there's the reparative part of the condition. This is the autoimmune area being addressed, possibly very effectively, certainly in a significant number of people. Also now we're seeing that, and Natalizumab is the first treatment that we're seeing with other drugs, is that it can actually improve some symptoms. And we're seeing people's, as I say, cognitive improvement, staying at work longer, improve their motor function, walking speed, reducing vision impairment, and improving their bladder and bowel symptoms. So these are positives that we see from treatment. And when people were on interferon previously, we weren't seeing many positives, but we're really starting to see gains from treatment. Now to come on to the risks. I mean, the main risk with Natalizumab is PML, a concern for all of us, an ongoing concern. There's three main risk factors for this, and that's the JCV antibodies. So anti-JCV, JC is this virus that causes a little cold, and we can now do a blood test to look for this. Whether people have used immunosuppressants in the past, now that had got less as we started. There are quite a few people who've been on immunosuppressant treatment, but that has changed now. But now it's possibly increasing as these other new drugs start to arrive, fingolimod and tecfidera, however they fit into this. And the other thing is how long you've been on the treatment, and it brings us to the big issue at what to do at 2 years when the risk does change, and it's an ongoing issue. The other thing is PML itself. The trouble was when it first started, it was fatal in everyone. But now that mortality is down to 1 in 6, but a third of people have no residual injury from having the condition. And what we're seeing now is that early detection, before it becomes symptomatic, can actually mean you can deal with it before it causes any problems. So almost being able to manage it effectively. So what is the JC virus blood test? Well, when you have an infection, you form antibodies to react to that virus, and those antibodies sit in your blood like when you've had measles or rubella, and you can pick that up now with the blood test. And if you are positive, it means you've had that infection in the past. Doesn't mean you have it there and then, in the past. So this blood test, what we see, it's a bit complicated, just to take you through, is that when we do the blood test, if you're negative, the risk is 1 in 10,000. I think there's one person ever. It's a sort of a statistical risk of having PML. Then you need to have the blood test done every 6 months to keep a watch on that. That's the idea. If you become positive, the people who have not had immune therapy, immune suppressants, and the people who have had it. So previously, this is where the risk was. But what we're now seeing is this is what we call the JC index, which is starting to emerge. So what we see, it's a bit complicated. If you look at the lower line, if your JC index is greater than 1.5, then your risk of PML at the first 24 months is 1 in 1,000, which is really what we've been quoting to everyone. But it does rise to 1 in 250 as we go beyond that length of treatment. But if it's lower than that, your risk remains very low. So progressive multifocal leukoencephalopathy. So, sorry. So that's a condition. Yeah. No. So that's the condition that when the JC virus, when it reactivates, it sits in the brain and sits dormant. But if the immune system goes down, it reactivates and it attacks the oligodendrocytes, the cells that myelinate. And so that's what we call it progressive. And if the immune system can be rebuilt, it actually can be killed and got rid of again and suppressed again. And one of our aims of treatment, I'm not going to talk a lot about it, is that we take the Natalizumab out of your body and we give lots of steroids, and that allows the immune system to go in. So Natalizumab stops the white cells getting into your brain. So that's why it allows that to happen. And then you try and clear that out of the system to get the immune system in there again. And if you get in earlier and earlier, you get better and better results. Not a desirable thing to have, but better results. So this index is just another way of trying to get people into higher or lower risks, which is important to try and understand whether we should be continuing the treatment. It doesn't apply to people who've had immune therapy, because that slightly shifts the balance about it. But so this is the thing that I was just going to talk a little bit more about. So where did this index come from? So this is from Biogen, the company that make Tysabri, and they started the test, and they allow us to do the test currently, which is done in Denmark. And they took samples from 2,000 people on treatment who didn't have PML, and they had 50 samples of people who did have PML. And they measured how high their index was in the people who eventually had PML. And when it was above 1.5, only very few people had PML in that group. So that's why how they calculate that risk. So it's based on this set of blood tests which they did, and then they replicated. So we've been doing the blood test now for some years, and really 2011 is when we first started doing it. And we were told that if you became positive, we wouldn't retest. And to become positive, 2% of people get infections a year. That's what we understand that to be. And about 50% of people were positive in 2011. Then in 2012, we were only measuring the negative people, and 30% became positive, which we were slightly alarmed about. And then we were told, well, they've changed the test. So the test was different. So suddenly we're not matching like with like, so that's a little alarming. But then when we rechecked the rates in 2013 with the new test, about 60% of people were positive. So we've slightly moved up from 48% to 58% were positive. Now, these are all numbers and statistics, but then we've done it again just recently. This year, we've checked everybody again, and we get a different number now. So 52% of people are positive now. So the numbers are varying. And there was a 13% chance that the blood test would change from positive to negative over 1 year, both from going from negative to positive and positive to negative. But if you went from negative to positive, there was about a 20% chance it might go negative again. So what we're looking at probably is an effect of blood testing. So blood tests are not absolutely perfect, and we get this variation. And the problem is, are we making decisions based on variation in a blood test? We then looked at the ratio, which we have sort of not talked about too much at the moment because it's not being published yet. But there's a 10% chance your ratio would change over 6 months. And if you are low positive, there's a 60% chance you might become high positive. That's over 6 months. So the blood test is moving around a little bit, which makes a little bit of a concern if you make decisions about whether it's good enough to decide to continue or stop treatment on that basis. So the other thing we know is that the PML risk increases with time. So there's lots of different graphs. This is the graph that I find most useful, is that if you've had 12 infusions, the risk is extremely low. And that's why we tell people, really in the first year, we don't see PML as an issue. So you get a year to try the treatment. That risk does rise up to about 37 infusions here and seems to stabilize. And what we're seeing is that the risk doesn't seem to rise once you've got to a certain level. There is a risk, but it does not rise. So it doesn't keep going up. This is another way of looking at these. This is a little bit more longer-term information that shows that essentially the risk gets to around 2 out of 1,000, 2.5 out of 1,000, and stabilizes for however long you've been on the treatment. These are people who've been on up to 72 infusions. So the risk gets to a point, and it stays at a certain point. So it's not an increasing risk, but it is a risk. Now, what's also emerged is that we've now been doing the MRI scans more regularly in people who are JC positive. So Biogen have gone back to look at that information and found that this is when people, at this end, when people were diagnosed with PML, and they went back to look at all the MRI scans. And what they found is that they can see a change on the MRI scan from about 6 months before people actually get diagnosed with PML. Therefore, potentially, this is when they don't have any symptoms, that they could be picked up early and could be treated effectively. And what's more, sorry, it's a very complicated picture, but if you look at the blue line, and this is when people get diagnosed with PML, this is their disability, so their score. when they get diagnosed with PML, their disability increases, so that it affects them. But if you take the people who are asymptomatic, who had no symptoms when they were picked up and treated, it makes very little difference. So that's what we're seeing, is that if we can pick it up early with a regular MRI scan, potentially we can be effective at treating this earlier. And so now we've started to institute 6-monthly MRI scans in people, and we may be evaluating how frequently we need to do this with Biogen. So managing risk is a key element of what we do. As I say, there's 3 main risks that we're concerned about, but the new treatments are possibly going to change what's risk or not risk. It gets more and more confusing with all these different drugs that people have been onto. But the key thing, which what we've always focused on and try to continue to focus on, is clinical vigilance with the regular MRI scan, and if we need to, a spinal fluid. Nobody wants a spinal fluid. What we do see is that a negative JC blood test is associated with a low risk, and 50% of our people who are JC positive have got low index, so a lower risk. The problem with the index at the moment is it's still going through the process of being published, and we're hoping that means it gets independent review of the information, which is why I was saying that we see these variation, as we do see changes over 6 months that have actually had some impact on people's decision making, which we need to be careful about and get right. So it's an ongoing process. I say we're going to probably relook at the index in everyone again in a couple of months' time, just to see how stable it really is. Lastly, I was just going to talk about new treatments and where do we go next if it's not working for you. So I think Paola's going to show this slide in a little bit, but we've got a lot of people on new treatments coming through. We've used a lot of other therapies, down to bone marrow transplantation. As I say, we've been in a number of studies. Natalizumab is a trial drug that's just come through a phase 3 study a couple of months ago and was effective, and these are studies in progressive MS. So there's lots of work going on, lots of work going on. The aim of treatment, and what Siddhartha was sort of saying, is that this is MS, little episodes. If we hit the condition early on at the right level, do we stop a change going on in the future by attacking the condition there, the immune side of the condition? That's the question. And if we wait too long, do we miss that boat and does it continue? And the question also is, do the actual treatments do this? So we're seeing long-term stability with Natalizumab, and sort of saying to us, maybe we are doing this. But now the question is, when do we change? When is it not sufficient to be doing this? And hopefully Professor Giovannoni will talk about this later. It's called no evidence of disease activity. So the idea that when we see people who've had problems clinically, it hides a lot more MRI activity and maybe a lot more damage going on, this iceberg that we're not attacking effectively early on. And should we be changing treatments if we can give a hint of something going on? This approach is quite aggressive, it's quite new, and it's whether it's the right thing for every condition actually still remains to be proven. And as I say, hopefully Gavin will talk about it later on and give us some more information on that. But again, it's a new way of looking at that. But then it says, well, what do we do next? So this is what's happened to the people who've been on the treatment for over 3 years here. About 20% of people have stopped that treatment. Some have had allergic reactions, sickness, infections, and antibodies. But about 18 felt it wasn't really working. A couple of people have stopped because of their risks of concerns about PML, and a couple of people because of pregnancy. So this is changing information all the time, but that's where we are at the moment. This is data from trials and work that's been done. It's published, came out, I think, as an abstract one of the meetings. It shows that when we start other treatments, so if we stop Natalizumab and we initiate other treatments, such as interferon, glatiramer, we do see that the MS starts to come back in that context. So we know that Tysabri is stronger than some of these treatments, but it seems that if we reinstitute them, maybe it isn't holding that condition down. But what happened here is about 13 people went on to, so the numbers vary a little bit, but 13 people went on to a further treatment, and 11 went on to Alantizumab, which is Lemtrada, which has just come out this week we're able to use on the NHS. In fact, what we found is about 70% of people who hadn't responded to Tysabri did actually respond to Lemtrada, but not everyone. And 2 people have gone on to some bone marrow transplantation, which actually they have responded to. So there is another way coming forward, but it's complicated. 2 people have gone on to fingolimod, and it's not really enough to know how much help that is or not from our point of view. There is some data that's been presented a couple of weeks ago in Boston, which was a big meeting about MS, and that sometimes the condition does look like it comes back again. So we're not sure about that yet. So what are your options? Well, if you're on Natalizumab, if it's beneficial, it's working. So probably there's the evidence at the moment says that this is working long term, so there's no real reason to do anything different at the moment. What's the risks of stopping treatment? Well, the MS can come back again. We've seen that previously with drug holidays, which we did a couple of years ago. Sometimes seen it in pregnancy, and also the trial data shows us that. The other option is going on a new treatment. That comes with its own benefits and risks. And we're still trying to be clear what those risks are, but we're starting to get maybe a inkling of that. Obviously, with treatment continuation, it's the PML risk, but that risk does appear to stabilize. So really, in conclusion, Natalizumab can make you feel better and stabilize the MS, but all drugs have risks, and at the moment, it's trying to understand that risk and accept that risk. But there's an evolving risk management strategy, so we're trying to get better at dealing with that risk, but nonetheless, the risk remains. What are the options if it doesn't work? Well, you can either stick with it. So some people who have been on it feel it's cut down where they would have been, so it has been helpful but not completely helpful. And how much do we pursue this NEDA approach of trying to get rid of everything? How effective will that be? We don't know yet. These new treatments are also coming through, but they can be more effective, but things like Lemtrada does come with its own risks, which I think Paolo will talk a little bit more about. Any questions?
Just going back to the JC virus and the JC negative, JC positive low, JC positive high. You gave some examples of people going from JC positive low back to negative, and people going from low to high. Has there been any signs of going from JC high back down to low again as well? I didn't see that reported.
Yes, sorry, 10% of people go back from high to low. Okay. And in fact, we've had people go from high positive back to negative.
Okay.
Besides the dodgy anti-malarial drug that does kill JC virus, is there any other drug that does the same thing?
I mean, at the moment, there are trials on some antivirals out there. I mean, the difficulty is that it's very rare. So even now, there's only a few hundred cases ever that's gone on. And so it's really difficult to know. And I think effectively with this approach with the MRI scanning and getting rid of the drug out of the system, it's difficult to know whether your own body treats that virus. And I think what we're seeing is if we can get it early enough, effectively your own body will get rid of that virus and suppress it. I mean, the problem is that then what drug do you use next? That's another question.
Also, if you were changing drugs and you have a washout period, will the person's MS get worse during the washout period before they start the new drug?
Well, the thing is that was this conference a couple of weeks ago, that was a big discussion about it, and people are concerned that waiting even 3 months allows the condition to come back again. And so we're seeing people reduce that time to 8 weeks. I mean, with interferon, people can just swap over, but with things like Lemtrada, there's people trying a little shorter time periods. But it's very difficult because it takes a lot of people to really answer that question. Things like the risk of PML may not be the same for each drug. That's the trouble. Lemtrada or Natalizumab or Campath has its own risks, as I say about it. So, but it's a thing that's really is a big concern because there's now 10 drugs licensed for MS out there. So people are going to be changing over medications much more commonly.
Good morning. Thank you for an interesting discussion. Question about the JC virus assay. That was obviously developed by Biogen to help neurologists and patients decide whether Tysabri was the right drug for them and the risks. Given what you've talked about, this kind of quite statistically large fluctuation between positive, negative, negative, positive, high, low titration, what are Biogen doing to obviously give more certainty to both neurologists and patients?
Well, exactly. So they actually, to be honest, at this meeting there was a lot of data. So what we've got is there's lots of people all over the world. So we are allowed to use that test for nothing, essentially, and evaluate it ourselves. So the information, they don't influence what we do with it. And what we hope to do is that when we are at this meeting, you meet people from Sweden, Denmark, all over the world using this assay with their results. Because also, PML appears to be different in different parts of the world. And why do people sometimes get it or not get it? So there's so much variation. So really, we can only do it by all working together. And to be fair on Biogen, they are facilitating us doing that. They allow us to do that, and they don't. So as I say, they don't have any influence on what we say. And I think we would like a test, and we're measuring it because we want to know the answer to give that information so we can make decisions. But the trouble is, are we making the right decision? And that will be influenced by the other drugs that come through as well. So it's sort of lots of things changing.
Last one question.
Hello. In regards to the increased risk of PML at 2 years, Richard, on Tysabri, some of my colleagues are reporting that in other centres, patients are being switched off routinely at 2 years onto fingolimod. I wondered what your view was on that.
The practice is very variable throughout the world. Some people will stop people automatically at 2 years of Natalizumab treatment, and quite a lot of the US they would do that, but parts don't. But this is what we're getting all this information about the condition coming back. And so fingolimod, there was some data that said that maybe the condition does creep back certainly in a subgroup of people who start fingolimod. But that is actually being looked at. We're now doing a study with Novartis, actually, to try and see if that really is so. So we await that real answer. And if we can effectively change people over to something else, well, that may be the right process. But people are doing it because of their concern about risk. But people we found has wanted to stay on it because it was effective. So it is a risk-benefit and hopefully a joint decision of where we go.
Tysabri or not? Thank you. So is that made aware to patients when they're making that decision? Because certainly a couple of years ago that wasn't the case.
Whether they're high or low positive?
Yes.
No, so we're not. Level. So we haven't told people whether they're high or low positive at the moment because we're not certain about that information, how stable it is. So whether people are positive or negative, but the high or low positive, we only started really getting that information with the testing we did for September or earlier this year.
But is the plan to advise patients? Because the difference in statistics is quite considerable.
Well, no, the problem is the plan is to try and give people that. The plan is that we would be giving people that index. But one way we do that is when it's published, it means that independent people have looked at it and decide that it's a good test.
Right, okay.
And so we're sort of waiting for all that information so we can make decisions. But certainly, it would have influenced decisions going from positive to negative. It has influenced already. And then it's gone back to negative again. And you're thinking, so it's not that we don't want to talk about it. It's what we want is that we can be relied to make it the right decision on that. And the statistics that you need, I mean, I show variation. All tests have variation. And it's just we accept certain levels of variation. It's just that the people who know about tests have done their work to say that this is acceptable for us. So I personally think that we will be telling it to you fairly soon. But we want just certainty around that.
Okay.
Yeah. Oh, well, all right. So one last. Yeah.
One more and then.
Okay, hello. Hello. It's very quick anyway. It's nothing to do with the JC virus, and I think that I know all about that. It was just with the Lemtrada. Do you consider that to be a drug that's equally as effective as the Tysabri with regards to percentage-wise of relapse, reduction in relapse rate, etc.? Because if the Tysabri is not working, it seemed that until recently there wasn't anything else on the market that would be a drug equal to its efficacy.
Well, I think Paolo's going to talk a little bit about that.
Oh,
but,
okay.
I think that's the big question. Is it really, so it looks, on the face of it, though it may be a level of equivalence about it, the difficulty is that the trials that have been done so far have all been done very early on. But I think Paolo will tell us a bit more about that, because from what we've done
So
here.
I led in well to your next talk.
Okay, all right, thanks.